And this lecture will be uploaded onto your class channel. So this will be the actual class lecture. There will be no class tomorrow. This is it. So if you got questions, absolutely speak up. This is Chapter 8, Pathophysiology. All right, so patho, your national standard competency, of course, integrates comprehensive knowledge of pathophysiology of major human systems. Pathophysiology is the study of physiology of altered functioning in the presence of disease. So when the body can no longer maintain homeostasis, that is when disease results. To understand the disease processes, you must understand the ways disease alters the structure and function in cells. Adaptations in cells and tissues. When exposed to adverse conditions, cells undergo a process of adaptation. Atrophy is a disease in cell size due to loss of subcellular components. So what happens when we see that atrophy? What does that mean?
It decreases in size.
Yeah.
Yes, it withers. It decreases in size. You start seeing weakness. Hypertrophy is an increase in the size of the cells due to synthesis of more. It gets bigger. Absolutely. Hyperplasia is an increase in the actual number of cells in an organ or tissue. Dysplasia is an alteration of the size, shape, and organization of cells. So what does that dys mean? That's your medical terminology again. The dys means that it's not functioning quite correctly. The dysplasia, you have the alteration of the cell. Dyspnea, you're not breathing correctly. You have difficulty breathing. Does that make sense? Okay, metaplasia refers to the reversible cellular adaptation in which one adult cell type is replaced by another. Okay. Disturbances in fluid balance. The human body is composed primarily of what? Water. So changes in fluid and electrolyte balance that disrupt homeostasis can either cause or exacerbate various disease processes. Excessive output or input of fluids can upset homeostasis. The degree of fluid imbalance required to compromise homeostasis depends on the patient's size, age, underlying medical condition. Fluid therapy is a fundamental step in resuscitation. So what's happening when we're going through homeostasis? What is homeostasis? The balance of it, the normal function. Everything is right in our universe. All right, edema. Y'all see those feet? We've seen those feet. We see a lot of feet like that. Some of us have those feet after we get off shift. Edema is swelling caused by excessive fluid trapped in the body tissues. Causes include the increased capillary hydrostatic pressure, allergic reactions or inflammation, venous obstruction, pregnancy, heat stress, decreased colloidal, there's another one of those words, osmotic pressure in capillaries. So that's the decreased production of plasma proteins in patients with liver disease or severe deficiency, increased loss of plasma proteins from kidney disease or extensive burns. Obstruction of lymphatic vessels can cause edema. The clinical manifestations of edema may be local or generalized. What does that mean for it to be local?
In one spot.
In one area.
In one spot. And generalized is going to be all over. An in-depth physical assessment includes auscultation of breath sounds. Why? Why do you want to listen to breath sounds if their feet are swollen? Absolutely. Evaluation for pedal and sacral edema and jugular venous distension. Evaluation of vital signs. Definitive treatment depends on the underlying medical condition. So you're going to see this in a lot of different kinds of patients, but primarily like dialysis patients, patients with congestive heart failure. Those are the ones that you're really going to see the peripheral edema stand out. Burn patients. Why would you see edema in burn patients?
Body trying to compensate.
Body's trying to compensate, and it's sending all these resources to the wounded areas to try to heal it. Isotonic fluid deficit. Isotonic fluid deficit is a decrease in extracellular fluid with proportionate losses of sodium and water. Most common form of fluid loss is isotonic fluid deficit. The isotonic fluid excess is a proportionate increase of sodium and water in extracellular fluid, and common causes of this include what we just said, kidney and heart failure. So your kidney patients, those are going to be your dialysis patients, heart failure, CHF. Electrolyte imbalances. Sodium regulates fluid balance, total fluid volume, and blood pressure in the human body. It also facilitates muscle contraction and nerve impulse transmission. Hypertonic fluid deficit occurs due to a disproportionate loss of sodium during water loss. Hypernatremia, what do you think that means?
Too much.
Sodium.
Too much sodium. So the hyper, let's break this down. Hyper is elevated. Natremia. So if you split that in half, we've learned that emia is what?
Blood.
Blood. So what is your, we're going back to the periodic table here, 5th grade science. What is your, the chemical for sodium? What is that, the letters for that? Na. So on your periodic table, you go and you look for sodium, you see Na positive. So if Na positive means sodium, what does hypernatremia mean?
Too much salt in the blood.
Absolutely, too much sodium in the blood. So that's going to be a serum sodium level of 143 or higher. We got somebody trying to get in to us. Caitlin. Okay. So, hyponatremia. What is that?
Not enough sodium in the blood.
Low level of sodium in the blood. That's going to be a serum sodium level of 135 or less. So causes of hypernatremia and hyponatremia will include excessive sweating and heat or during exercise. Why would sweating cause that?
Because you're losing
You're wetting out
fluid.
your bowl.
Yeah, your sweat is salty. Your face ever been sweating and you licked your lips? Tastes pretty salty. GI losses through vomiting and diarrhea. Inappropriate use of IV fluids. So, how would inappropriate use of IV fluids cause this?
If you give too much, you're going to wash away the sodium.
Absolutely.
Probably through the bladder.
Absolutely. So, too much fluids, you're diluting what's already in there. So, you're going to have the hyponatremia. People don't realize that you can actually cause problems by giving fluid. All right, your potassium. This is crucial to many cellular functions. A normal serum level of potassium ranges from 3.5 to 5.0, and that is milliequivalents per liter. What are we talking about when we say serum, a serum level? We're talking about the blood. When they do the blood test and they test your blood for all this different panels, this is where they're getting this from. Hypokalemia, what does that mean? Low potassium. So where are we getting potassium from? Your periodic table. Ka, your periodic table Ka is the symbol for potassium. So hypokalemia is a decreased serum potassium level. This may be caused by decreased dietary potassium intake and absorption, decreased shift of potassium into the cells, renal potassium loss, extrarenal potassium loss, hyperkalemia, which would be what?
Too much potassium in the blood.
Yes, an elevated serum potassium level. Those causes could be decreased excretion, shifts of potassium from within the cell, or excessive dietary potassium intake. Where do you think we get the sodium from? And we're talking about dietary stuff. Where do we get sodium from? From salt, food. Just you wouldn't realize how much sodium is in stuff. Coca-Cola through the roof for sodium. Potassium. What are some things that have the potassium in it?
Potassium is potatoes.
Bananas.
Okay.
Bananas.
Bananas, yogurt, tomatoes. So,
Avocados have a lot of
Stacy,
yes.
Caitlin wanted me to tell you that it kicked her out.
Okay, all she's got to do is sign right back in. It's showing me that, yeah. All she's got to do is go back to the link and it should let her sign right back in. And if not, if she's on the track with you, she can listen with you. Okay, so the normal serum potassium levels are 3.5 to 5.0. We went through hyperkalemia and hypokalemia. Okay, moving on. So next we have calcium. So calcium, nearly all or 98% of the body's calcium is found where, would you think?
The bones.
The bones, and where else?
The blood.
The teeth. It lends strength and stability to the collagen and ground substance that form the matrix of the skeletal system. It enters the body through the GI tract. A normal serum calcium level ranges from 8.2 to 10.2 milligrams per deciliter. Hypocalcemia, what would you think that is?
Not enough calcium.
Not enough calcium. Decreased serum calcium levels. Causes are decreased calcium intake or absorption. So that means that it may not be that you're not getting enough calcium. Your body may not be absorbing it. You have to keep that in mind. A lot of GI illnesses will keep your stomach and your intestines where these nutrients are absorbed. If you have a GI disease that decreases your absorption, it doesn't matter how much you're taking in as far as your dietary amount goes. Your body has to also be able to absorb that. Does that make sense?
Absolutely.
Okay.
It does.
Increased calcium loss. Where would you have calcium loss from? So if you've got, where's calcium found in your body? Your bones and your teeth. So if you have, let's say, osteoporosis and your bones are deteriorating, would you agree that you would have calcium loss?
Absolutely.
So, okay, endocrine disorders.
Or at least it's not making it to the bones.
Right. Endocrine disorders, sepsis, those are all causes of hypocalcemia. Hypercalcemia, increased serum calcium level. Those causes could be increased calcium intake or absorption, endocrine disorders, and also neoplasms. Cancer.
Oh, yeah, you're right.
Okay, so this slide shows the electrolyte imbalances. It shows the regulation of blood calcium level. Make sure you're familiar with that. That's going to be figure 8.3 in your book. Phosphates. These are primarily an intracellular anion essential to many body functions. Hypophosphatemia. What would that mean?
Too much phosphate in the blood.
Not enough phosphate.
Not enough phosphate in the blood. A decreased level of serum phosphate. Causes include a decreased supply or absorption, excessive loss of phosphate associated with the use of diuretics. What do diuretics do?
Make you pee.
They make you pee. So if you increase your urine output, then you're flushing this stuff out of your system. Intracellular shift of phosphorus, electrolyte abnormalities, abnormal loss of nutrients followed by inadequate replenishment, hyperphosphatemia, which would be what?
Too much phosphate in your blood.
Too much. That could be massive loading of phosphate into the extracellular fluid, decreased excretion into the urine.
I've noticed that dialysis patients take phosphate binders. That would be for the hyper.
So when you take binders, that is a chemical that's kind of, if you're old school and you remember, like charcoal, activated charcoal. What was that?
It was a binder.
It was a binder.
A suspension binder.
Yes. So let's go back to that slide where it's talking about decreased excretion into the urine, especially with dialysis patients. So if they are not excreting this particular enzyme into the urine, then they can take the binders that will latch onto them to help them eliminate those. Does that make sense?
Yes, because dialysis patients don't pee a lot.
Right. So their output is decreased, and that's just something else too. They go through, the mechanical cleansing of their blood on their dialysis days, but the days in between, and they do need that little extra because it could be when their kidneys are not functioning properly, but they're also on a fluid restriction, so they're not drinking enough to really push that urine. It's kind of a double-edged sword with those patients. Not only is it not functioning properly for them to urinate, but they also aren't putting a lot in to be able to urinate. So they need that extra little help to bind a hold of those so that they can be excreted in urine as much as possible.
Cool.
So your magnesium, 50% of the body's magnesium is stored in the bones, 49% in other body cells, and the remaining 1% is the extracellular fluid. A normal range of serum magnesium is 1.3 to 2.1 milliequivalents per liter. Hypomagnesemia, I can't even say that, y'all. Hypomagnesemia. I think we should do like, it really is. It really is. I think we should do like a reverse spelling bee where I line all y'all up and I spell the word, and whoever can pronounce it correctly gets points. And say who the last one standing is.
I can only tell.
Yeah. Poor Maddie. Maddie, we'll put you in the corner, and like every time we get to you, just spell corner. You can be the mascot. Maddie's our mascot. Yes. Okay. So this is a decreased level of serum magnesium. It includes causes of diminished magnesium absorption or intake. Y'all see the pattern with this? The number one cause of all of these is either diminished absorption or intake. Increased renal loss of magnesium, or miscellaneous causes such as diabetes, respiratory alkalosis, and pregnancy. Hypermagnesemia. Hypermagnesemia. Y'all, we're just going to roll with it. Don't talk about me. An increased level of serum magnesium. This almost always occurs as a result of kidney insufficiency. So, again, why would that be? Just like with the phosphates. Just like with the phosphates, they're not able to eliminate this stuff. So it builds up.
Yeah. My magnesium stays in the basement, though.
Does it?
Yeah, mine stays about 0.9. Freaks the doctors out every time they do blood draw.
Well, hey, that's always fun.
Oh, yeah.
So Table 8.2 is going to summarize the major electrolytes of the body. And you'll see that in your book. So disturbances of the acid-base balance. pH is a measure of the acidity or alkalinity of a solution. The lower the pH, the higher the acidity.
I almost feel like I have an unfair advantage on this stuff right here.
Well, and if you know something that's going to help the others learn, by all means, jump in.
Okay.
Hey, I have a trick for that. We're all for tricks.
I rode that ride.
Yes. So acidosis is an increase in the extracellular hydrogen ions. Hydrogen is going to be H+. Alkalosis is a decrease in extracellular hydrogen ions. Disturbances of acid-base balance are associated with disturbances of potassium balance. This is a nice little figure to try to help explain this. So, different types of acid-base imbalances. This respiratory acidosis is always related to hypoventilation. That sounds like a great test question, right? Respiratory acidosis is always related to hypoventilation. Causes could include airway obstruction, cardiac arrest, overdose of a central nervous system depressant drug, submersion, respiratory arrest, pulmonary edema, closed head injuries, and chest trauma. Does it make sense to you how all of those causes lead to hypoventilation?
It does, except the head injury.
The head injury. So, where does your body get the instructions and the direction to breathe from?
Brain, cerebellum.
From your brain. So, if you have a head injury, if you have a brain injury, if you have an increase in your intracranial pressure, if you have a bleed that's pressing on the brain, swelling, edema, any of those things are going to lead to some type of problem or pressure on your brain. And when you think about head injuries, especially closed head injuries, open head injuries have more room to let pressure out. Blood's not building up, blood's coming out. You're still going to have brain injuries, but especially with closed head injuries, you're going to have a lot of pressure building up. There's not a lot of room in the skull for the brain to be able to compensate for any amount of swelling. Does that make sense?
Yeah.
So you break your arm, you break your leg, even something in your abdomen, you've got a lot more room there for the body to swell, have edema, and things like that without causing too many problems. You get a minimal amount of room inside the head for anything to go wrong with the fluid, with the tissue itself, before it causes a shift in the brain.
That's why doctors in emergency situations give a craniotomy. I believe that's the correct word.
Yeah, craniotomy is the correct word. So, those are just things to think about. So that's why a head injury could cause hypoventilation. Does that make sense to everybody?
Yes.
Everybody other than Blake?
Yes, it does.
Okay.
Yes.
So why would chest trauma lead to hypoventilation? Let's go through these.
Injury to the pleural cavity.
Injury to the pleural cavity. Airway obstruction. Obvious.
Yeah.
Cardiac arrest. Even
the heart stops, breathing comes up.
Yes. So overdose of a CNS depressant drug.
It's gonna slow your breathing down.
Submersion.
That would be the diving reflex that would kick in on that, right?
Mammalian diving reflex. That causes bradycardia.
Oh.
I want some other people than Blake to jump in. Like, I love Blake answering. I'm feeling it, but I need some input from y'all. Pulmonary edema.
Because you're not getting air across, like it's covering it.
Yes, you've got the fluid in there that's keeping you from being able to get that air exchange. Okay, so signs and symptoms of respiratory acidosis. This includes systemic or cerebral vasodilation, or both. Headache, lightheadedness, warm flushed skin, CNS depression, bradypnea or a slow respiratory rate, and nausea and vomiting. All right, respiratory alkalosis is associated with conditions that result in hyperventilation. Okay, we just talked about hypoventilation. Now we're talking about hyper. The level of circulating carbonic acid is reduced. Hyperventilation accompanied by carpopedal spasms is the classic sign of respiratory alkalosis. That sounds like a good test question. Causes of hyperventilation and respiratory alkalosis include drug overdose, fever, or overzealous bag mask ventilation. Signs and symptoms include diminished level of consciousness, lightheadedness, carpopedal spasms. There's another one of those big words. Paresthesias of the lips and the face. Chest tightness, confusion, vertigo. What's vertigo?
Being dizzy.
Yes. Blurred vision, nausea, and vomiting. Metabolic acidosis. Any acidosis unrelated to the respiratory system is considered metabolic. Okay, any acidosis unrelated to the respiratory system is considered metabolic. Causes of metabolic acidosis include lactic acidosis, ketoacidosis, aspirin overdose, excessive alcohol ingestion or alcoholic ketoacidosis, gastrointestinal losses, carbon monoxide poisoning. Signs and symptoms include vasodilation, CNS depression, headaches, warm flushed skin, tachypnea. What's tachypnea? Anybody?
I can't remember that one.
So what does tachy mean?
To give you a fast breathing time.
It is, mighty. Very good. Tachypnea is rapid breathing. It's a fast breathing rate. So tachy, medical terminology, tachy means fast. Tachycardia, fast heart rate. Tachypnea, fast respiratory rate. All right, nausea and vomiting and circulatory dysrhythmias. Metabolic alkalosis occurs due to an excessive loss of acid. This is rarely an acute condition, but is common among chronically ill patients. Causes would include excessive vomiting, excessive water intake, nasogastric suctioning, and excessive intake of alkaline substances. Signs and symptoms of this include confusion, muscle tremors, cramps, bradypnea, and hypotension. What's bradypnea?
Slow breathing.
Slow breathing. Very good. Cellular injury. Various processes may cause cellular injury. Hypoxia, which is a lack of oxygen. Ischemia, which is lack of blood supply. Chemical injury, infectious injury, immunologic hypersensitivity injury, physical damage, which is mechanical injury, or an inflammatory injury. Manifestations of cellular injury occur at the microscopic or structural and functional levels. Common microscopic abnormalities include cell swelling, rupture of cell membranes or nuclear membranes, breakdown of nuclear material such as chromosomes. Functional disturbances may include inefficient oxygen utilization, intracellular acidosis, toxic waste accumulation, and derangement of nutrient metabolization. So dysfunction in one system inevitably affects the function of other systems. Cellular injury can be repaired up to a point with proper treatment. So what do you think happens when the cellular injury occurs? And it says dysfunction of one system inevitably affects the function of other systems.
They can't get stuff to the tissues or the organs.
Exactly. So if you're thinking about this on a cellular level, what do we say? Cells make up what?
Tissues.
Tissues make up,
Organs.
and organs make up systems. And where does especially when we're talking about respiration, not breathing respirations, but your gas exchange, the actual respiration of the cells. So if we have these injuries on a cellular level and they're not able to exchange these gases and they're not able to pick up the oxygen and they're not able to throw off the waste, then what happens as this continues and slowly builds up? It goes more than the cellular injury itself, then causes problems for the tissue. Right, the tissues, and then it spreads from the tissues to the organs, and then from the organs to the entire system. So, in case you're wondering why we're having to take it to a cellular level, this is why. Because over time, it's going to inevitably affect the function of the other systems. Hypoxic injury. This is common and often deadly cause of cellular injury. It may result from decreased amounts of oxygen in the air, a loss of hemoglobin function. Let's talk about that. So, why would a loss of hemoglobin function lead to a hypoxic injury?
They can no longer carry oxygen.
Very good. Fun fact, let's just say who knows how many molecules of oxygen can the red blood cell carry? Does anybody remember that?
Is it 7?
No.
Well, I'm at a loss again.
Somebody find that. Somebody come back and tell me how many molecules of oxygen a red blood cell can carry. So a loss of hemoglobin function. If the hemoglobin are not functioning properly, then they are not carrying oxygen or not carrying it at their max capacity, which leads to hypoxia. What is hypoxia?
Hypoxia is not getting enough oxygen.
Not getting enough oxygen.
And it's sore.
Very good. So, everybody thank Jessica for the answers. Nobody cares. Thank you, Jessica. I appreciate your service.
Yeah.
Thank
Don't
you for
listen to me. I'm not doing too good on tests.
Thank you for your service. So, a decreased number of red blood cells. Why? We just discussed this. Why would a decreased number of red blood cells matter?
Because your body's not getting oxygen.
Your body's not getting oxygen. Disease of the respiratory or cardiovascular system, and loss of cytochromes. So all of these things can result in a hypoxic injury. Cells that are hypoxic for more than a few seconds produce mediators, which lead to more cell damage. So free radicals are the earliest and most dangerous mediators produced by cells. This sounds like a lot of great test questions, y'all. Free radicals are the earliest and most dangerous mediators produced by cells. All right, a chemical injury. A variety of chemicals may injure and ultimately destroy cells. Common poisons include cyanide and pesticides. Cyanide induces cell hypoxia. Pesticides prevent proper transmission of nerve impulses by blocking the enzyme. This is one that's going to take me a minute. Acetylcholinesterase. Wasn't as hard as I thought it was going to be. Long-term ingestion of lead leads to brain injury and neurologic dysfunction. If I ever look at you and tell you that you ate paint chips as a kid, this is what I'm talking about. Long-term ingestion of lead, paint back in the day had lead in it, leads to brain injury and neurologic dysfunction. Carbon monoxide prevents adequate oxygenation of the tissues. Why is that?
Because it binds the hemoglobin better than oxygen.
Absolutely, very good. So when it takes its place on the red blood cells, it has a greater affinity and it is more powerful and more strong than the oxygen molecules. So the oxygen molecules cannot bind when the carbon monoxide is there. So therefore it prevents decreased oxygenation. Higher doses of ethanol produce severe CNS depression and hypoventilation. Infectious injuries. These occur as a result of invasion of bacteria, fungi, or viruses. Virulence measures the disease-causing ability of a microorganism. A depressed immune system is less capable of fighting off microorganisms. White blood cells release endogenous pyrogens, and viruses take over the metabolic processes of the host cell and use the cell to replicate. A virus consists of a nucleic acid core of ribonucleic acid, RNA, or deoxyribonucleic acid, which is DNA. Many bacteria have a capsule that protects them from ingestion and destruction by phagocytes. Remember when we talked about that PHAGO means to what? To eat. So those cells, the phagocytes, are strictly there to break down and decompose these bacteria by eating them and consuming them. So what happens? They adapt they now have this capsule that wraps around them and protects them from being consumed by these other cells. And that's what you're seeing in that picture there. Immunologic and inflammatory injury. Inflammation is a protective response occurring in the presence of cellular injury. Inflammatory response can be triggered by a physical, chemical, or microbiologic agent. Signs of inflammation are heat, redness, tenderness, swelling, and pain. If the inflammatory process is severe, systemic effects become evident. A person feels ill and body temperature is elevated. The bone marrow accelerates the production of leukocytes, so the number of leukocytes circulating in the bloodstream increases. This is called leukocytosis. And the outcome of an inflammation response depends on the amount of tissue damage. So the bone marrow accelerates its production of leukocytes so that the number of leukocytes circulating in the bloodstream increases, and this is the image that's supposed to help you understand that. So genetic factors are going to be an abnormal gene may develop by mutation of the gene during meiosis or by heredity, and as a result of other causes later in life. Genetic factors that may damage cells include chromosomal disorders, premature development of atherosclerosis, and sometimes obesity. Nutritional imbalances, causes for this are obesity, malnutrition, vitamin excess or deficiency, and mineral excess or deficiency. Yes, you can take too many vitamins. Physical agents or conditions. So physical agents such as heat, cold, and radiation may cause cell injury, burns, frostbite, or radiation sickness. And the degree of cell injury is determined by the strength of the agent and the length of the exposure. Apoptosis. It is normal cell death. I would remember that. It's genetically programmed into the cells as part of normal development, organogenesis, immune function, and tissue growth. Unlike in the case of cell death from disease processes, proteins and DNA undergo controlled degradation that allow their remnants to be taken up and reused by neighboring cells. Areas that have undergone apoptotic death. That always makes me think of Pop-Tarts, y'all. I don't know why, but it does. Apoptotic death do not show any evidence of inflammation. Why? Why would you think that's the case?
Because it's a process, it's a normal process.
Exactly. It's normal. It's programmed to do this. This is part of its life cycle. It is not doing this because it's sick or it's injured. It's doing this because this is what it's supposed to do. So it is not going to have inflammation. It's not trying to heal itself or recover from this. It can be activated prematurely by pathologic factors such as cell injury. Inhibition of the normal course of apoptosis allows destructive cellular proliferation. And this illustration, figure 8A, shows the process by which cancerous cells develop from normal cells. Take a second to look at that. So these are different things that can affect the normal cell. You've got viruses, radiations, chemical carcinogens. What's a carcinogen?
Things that cause cancer.
things that cause cancer. And then you've got all these unknown factors. The unknown factors can be, genetic makeup, it's your genes, it's hereditary, things like that. How they affect a normal cell to become an abnormal cell. And if your immune system is ineffective, then those cells can continue to grow abnormally, causing neoplasms or cancer. If your immune system is effective, it can cause destruction of this abnormal cell. Okay, so just because I had skipped to the next slide while we were recording before Blake asked that, and I tried to go back, and of course it deletes lecture for that slide. So we're going to have to go over this one again, just so I'm not having to re-record your lecture. So Tiffany, be prepared to read that again, okay? So abnormal cell death is necrosis. It is the term for tissue death, and it results from the morphologic changes that occur following cell death. So you have simple necrosis that refers to areas of necrosis where gross and microscopic tissue and some of the cells are still recognizable. It may be caused by acute ischemia, acute toxicity, or direct physical injury. Then we have the derived necrosis, caseation, dry gangrene, fat, and liquefaction necrosis. Blake, you asked what liquefaction necrosis is.
Yes, ma'am.
And Tiffany?
Liquefaction necrosis results from coagulation necrosis followed by conversion of tissues into a liquid form and invasion of putrefying bacteria that grow rapidly in a warm, moist environment. The bacteria produce lactic enzymes and gas.
Very good. So does everybody have that? Everybody understand that?
I got it.
Yeah.
Very good. Okay, hypoperfusion. So this is the delivery of oxygen and nutrients and the removal of waste by the circulatory system. Adequate circulation depends on a pumping heart, an intact vascular system, and appropriate amount of oxygen-carrying blood. Hypoperfusion occurs when the level of tissue perfusion decreases below normal. In response to hypoperfusion, body releases catecholamines such as epinephrine and norepinephrine, which produce increased strength of cardiac contraction. This increases the pulse rate, vasoconstriction occurs, and increased systemic vascular resistance. As hypoperfusion persists, myocardial stress increases. What is hypoperfusion? What does it lead to?
Well enough.
It leads to shock. Shock is an abnormal state associated with inadequate oxygen and nutrient delivery to the metabolic apparatus of the cell. This results in impairment of cellular metabolism and inadequate perfusion of vital organs. If the body's compensatory mechanisms are sufficient to stabilize the patient's condition, the shock is called compensated shock. If hypoperfusion overwhelms the normal compensatory mechanisms and the patient's condition progressively deteriorates, it is decompensated or hypotensive shock. The types of shock. So shock can occur as a result of inadequacy of the central circulation or of the peripheral circulation. So central shock, you're going to have cardiogenic. This occurs when the heart cannot circulate enough blood to maintain adequate peripheral oxygen delivery. All right. Most common cause of cardiogenic shock is a myocardial infarction. Obstructive shock occurs when the blood flow becomes blocked in the heart or the great vessels. Does that make sense?
Yes, ma'am.
So again, cardiogenic, You got a problem going on with the heart. The heart cannot circulate enough blood itself. Obstructive shock, it's a heart problem. Obstructive, you have an obstruction. You have something there that is blocking that blood from getting through. Okay? This is what a cardiac tamponade looks like. This is following a myocardial rupture. On the left, you have a distended pericardial sac, and on the right, the pericardial sac is opened, showing the clotted blood surrounding the heart, which compresses the heart and prevents the ventricle from filling up in the diastole phase. Does that make sense? Just like we're talking about with the brain, you don't have much room in there for any swelling and things like that. You've got this small sac that surrounds the heart, and you have just enough room in there for the heart and the fluid that's supposed to be there to cushion it as it's pumping so that it's not rubbing up against the chest wall. When you have that fill up with blood, then you have cardiac tamponade. It tamponades it. It squeezes around it and it confines it to where it can't pump anymore. Something you'll learn in paramedic, which I expect all of you to be moving on to, and some people may be Grey's Anatomy fans and seen that, but just a fun fact, you're not supposed to know this. I don't expect you to know this, but if you do, I think it'd be really cool. So the way that they relieve a tamponade is to insert a needle just into the sac and to pull blood out to relieve that pressure. Okay?
Is that what they did to Mark?
So, how much blood? Haven, I expect you to know this answer since you're obviously a Grey's Anatomy fan.
I can't remember.
So fun fact: how many Grey's Anatomy fans do we have?
Me. Me. Hey.
There's got to be more, y'all.
I'm a big fan.
So this is the episode. This is and y'all had such a great one.
I just had my hands wet.
Okay. When I went through medic, it just so happened that everything I learned lined up. I swear to God, Shonda was in my medic class and writing the script to go along with what I was learning. Because what I would learn, I swear, would be on that TV on Thursday night. And so I thought it was really cool, and it stuck in my mind because I had actually just learned about cardiac tamponades when this happened. But this is the episode where the ambulance is flipped upside down outside of the ER, and Meredith has to go in and climb inside the cab with it upside down, and she has to relieve a cardiac tamponade on one of the medics. So, how much, if you just picture a syringe, and give me a guess if you don't know, you know what size syringes we carry on the truck. How much blood do you think is pulled out to relieve this tamponade?
3 cc's.
Nope.
60.
Nope.
5 cc's.
20?
20. Who said 20? Daniel. Daniel's my winner. 20 cc's.
He Googled it.
Well, hey, you know.
Wow, yes.
But look, hey, I'm okay with Google. Sometimes it's not knowing the answer, it's knowing where to find it. So if I ask you a question and you Google that and you spit it out before anybody else, you're still a winner in my book because you at least put forth the effort to find it.
What's that?
I'm okay with Google. Google makes my reports be spelled accurately a lot. Okay. This illustration shows the sites of a thoracic aortic dissection. A tear in the ascending aorta causes proximal and distal dissection. A tear in the descending aorta may cause extensive distal dissection. Looks like little giraffes, don't it? Okay. Peripheral shock. In hypovolemic shock, the circulating blood volume is insufficient to deliver adequate oxygen and nutrients to the body. Two types of hypovolemic shock are exogenous and endogenous. Distributive shock occurs when there is a widespread dilation of the resistance vessels and the capacitance vessels, or both. Everybody understand those? Hypovolemic, what do you think that means?
Blood volume loss.
Low volume. Distributive shock, somebody break that down, make it make sense. So, easy way to remember that, distributive. So it's widespread. It is distributed out amongst other things. Does that make sense? Keywords to make it make sense.
It just makes it.
Okay. Anaphylactic shock. What do you think that means?
An allergic reaction.
Allergic reaction. It occurs when histamine and other vasodilator proteins are released on exposure to an allergen. Septic shock. What is that?
Infection.
Infection. Occurs as a result of widespread infection. Neurogenic shock. This usually results from spinal cord injury. What part of the system is the spinal cord? What areas are we dealing with the spinal cord?
The back.
It's part of the neuro system.
From nerve.
Neuro deals with spinal cord. Makes sense, right? Okay, figure 11. This shows how damage to the spinal cord can cause substantial injury to the part of the nervous system that controls the size and muscle tone of blood vessels. If the smooth muscle of the blood vessels is cut off from its impulses to contract, then the vessels dilate widely. This increases the size and capacity of the vascular system. The blood in the body can no longer fill the enlarged vessels, which results in adequate perfusion and neurogenic shock. Does that make sense to everybody?
Yes.
So if you're looking at this normal vessel and the normal size, and then you've got this dilated vessel, you've got the same amount of blood. You've got the same pressure of the blood that's pumping through the body. But when you look at a normal amount and normal pressure of blood going through a normal vessel versus this dilated vessel, it pretty much just dumps. Does that make sense?
Yes.
Okay. It would be about, for our firefighter lovers, you're taking the amount of water and the pressure from the water hose of the hose we use to wash our trucks, just a little garden hose. You try to take that same amount of, and it might come out it's fast enough and it's strong enough and it's enough to wash our trucks. But you take that same amount of water and that same amount of pressure and try to run it through a fire hose, what's it going to do?
It's just going to pee out.
It's just going to pee out. It's just going to roll. It's going to trickle. It's not going to be forceful. It's not going to be worth nothing. So that's kind of like what's going on here. When those vessels dilate, that's the effect that you're getting with the blood. If you can picture that in your head, make that make sense. All right, managements of shock. Most types of shock are characterized by reduced cardiac output, circulatory insufficiency, and rapid heartbeat. To determine the presence or absence of shock, evaluate the presence and volume of the peripheral pulses and assess end organ perfusion and function. Prolonged capillary refill time indicates shock. What's a normal capillary refill time?
Again, less than 2 seconds.
Less than 2 seconds. So mottling, pallor, peripheral or central cyanosis, and delayed capillary refill may signal the presence of shock. What's mottling?
Where the skin looks great.
What's pallor?
So that pale.
Very good. Cyanosis.
Blue.
Boo-hoo. Okay. So those are all signs of the presence of shock. All right. Multiple organ dysfunction syndrome. Multiple organ dysfunction syndrome, or MODS, is a progressive condition that occurs in some critically ill patients. It is characterized by the concurrent failure of two or more organs or organ systems that were initially unharmed. Respiratory, hepatic. What is hepatic?
Isn't that the kidneys?
Nope, keep coming.
Liver.
Liver. So respiratory, hepatic, which is liver, renal, that's the kidneys, hematologic, neurologic, and cardiovascular systems are surveyed in diagnosing MODS. Overall mortality rate varies widely depending on the underlying etiology and ensuing diagnosis and treatment. So MODS occurs when injury or infection triggers a massive systemic immune, inflammatory, or coagulation response accompanied by the release of toxins. So primary MODS is a direct result of an insult such as a pulmonary contusion. Secondary MODS is a slower, more aggressive organ dysfunction. Okay? So primary is the direct result of an insult, and secondary is slower, progressive organ dysfunction. All right, the immune system includes all structures and processes associated with the body's defense against foreign substances. Several anatomic barriers decrease the chances of foreign substances invading the system. Examples include skin, hairs in the upper and lower respiratory tracts, and acid in the stomach. So how are these self-defense? Somebody, of course, your skin. What's your skin do?
Block stuff out.
It blocks stuff out. It keeps all this bacteria and stuff. People walk around. I mean, how many patients have you seen that have staph infection, the MRSA? Everybody has staph on their skin. It's a natural bacteria that is on everyone's skin. However, your skin remaining intact and not being broken, abrasions, lacerations, things like that, it keeps this bacteria from entering into your system. How do the hairs in your respiratory tract keep you healthy?
Because they filter bacteria.
Absolutely. Acid in your stomach?
It kills it.
Very good. So the immune response, the body's defense reaction to any foreign substance, is directed against invading microbes, bacteria, or viruses, foreign bodies, and abnormal cell growth. The innate response starts first and is then reinforced by the more specific acquired response. Components of the cell wall then activate the complement system. Chemotaxins attract leukocytes from the circulation to help fight the infection. Complement cascade ends with the formation of a set of proteins called the membrane attack complex. Types of immune system cells include basophils, eosinophils, neutrophils, monocytes, lymphocytes, macrophages, mast cells, plasma cells, B cells, which is B lymphocytes, helper B cells, memory B cells, T cells or T lymphocytes, and killer T cells. Natural native immunity is a nonspecific cellular and humoral or antibody response that operates as the first line of defense against pathogens. With acquired immunity, the immune system will never fail to recognize the same stimulant when it is subsequently encountered. Passively acquired immunity is the receipt of preformed antibodies to fight or prevent infection. The primary initial immune response takes place during the first exposure to an antigen. An antibody binds a specific antigen, and y'all can't even talk me tongue now. Immunogen is an antigen capable of generating an immune response. A hapten can be combined with an antigen to initiate a specific antibody response on its own at a later time. In humoral immunity, B-cell lymphocytes produce antibodies called immunoglobulins. B cells are born in the bone marrow and must be first activated to produce antibodies. The antibodies secreted by B cells are called immunoglobulins. So this is, and I don't know how much detail this is going to go into with this. The way I learned this in Medic was, and I always try to relate it to something or find something that can make it make sense to me. And my text primarily focused on the B cells and the T cells for an immune response. So if you look at your immune response as warfare, something has invaded your body, and now we're going to send this army to kill it and try to keep it from killing us or attacking us. We have these B cells and we have these T cells. And they act in a certain order in the immune response. And the way I remembered that order was because your T cells, they attack first. They're your front line. They come out first and they do their thing. If you look at it from a military standpoint, do we just send our soldiers into this war zone? We just hand them guns and let them run? No. What do we do? What do we send in first? Somebody give me something.
Air support.
We're going to send in tanks. T cells for tanks. All right. We're going to send our tanks in. They're going to clear the path for us before we let our boys just run in, right? And then we've got the B cells that come in behind the T cells. They're not as strong and as destructive and as powerful, but they're still very, very important in this defense mechanism. So I called the B cells the boys in the back. Does that make sense? We send our tanks in, then we send in our boys in the back. So T cells first, then B cells. Thank you, Stacy. We'll remember this now. Are y'all still with me? Are you still with me? Are you alive? Are you breathing? Are you listening?
I'm alive, breathing, and listening.
Thank you. I can't see you guys. When I'm sharing my screen with you, if you can see my screen, it's kind of like the 18-wheelers. If you can't see my mirrors, I can't see you. If you can see my screen, I cannot see your screen. I'm sharing my screen with you. So I don't see your face. I don't see your name. It doesn't tell me who leaves and who's trying to come in. I can only see my screen that I'm sharing with you. So if I don't hear you guys and you don't respond to me, I have no idea if I'm even on here by myself. And that's okay. I can sit and talk to myself. It's fine. But I think that this stuff is a little helpful for you. So the illustration, figure 812 in your book, shows you how those antibodies work. All right. So you have antigens and antibodies. They combine to form this antigen-antibody complex. You have complement activation. This produces membranes, attacks complexes, You have the precipitation. I don't know why I'm trying to read this to y'all. Agglutination and neutralization. So that's all part of your immuno response system. Here at the bottom, it's showing you, we've talked a lot about this, the phagocytosis. Those are those phagocytes. And if you look at that picture, y'all can actually zoom in on it, and while I zoom in on it, but where we keep telling you the phago means to eat, it actually looks, I mean, in that cell is consuming the other cell, but it actually looks like a little mouth, like it's eating, kind of like a Pac-Man. Okay, so immune response. These antibodies make antigens more visible to the immune system in 3 ways. So the antibodies act as opsonins. In opsonization, an antibody coats an antigen to facilitate its recognition by immune cells. What did we say facilitate meant? It's helping it. Very good. So the antibodies cause antigens to clump. Antibodies bind to and inactivate some toxins produced by bacteria. Cell-mediated immunity is characterized by the formation of a population of lymphocytes that can destroy foreign material. Subgroups of T cells are killer T cells, helper T cells, suppressor T cells, memory T cells, and lymphokine-producing cells. So your immune response, this illustration shows B cell activation. Immunocompetent B cells are stimulated by the presence of an antigen producing an intermittent cell, the lymphoblast. A lymphoblast divide producing plasma cells and some memory B cells. Memory B cells respond to subsequent antigen encroachment, yielding a rapid secondary response. Figure 814 shows the interaction of cell-mediated and humoral immunity. A macrophage presents processed antigen fragments to the T lymphocytes. The B lymphocyte processes the intact antigen and displays fragments of the same antigen on its cell membrane. The T lymphocyte, which has responded to the same antigen, stimulates the B lymphocyte to proliferate and mature into plasma cells and make antibodies. So these illustrations show the general structure of an antibody. Immunoglobulin G, or IgG, is a monomer. It is one molecule. That's what the mono in monomer means. Mono is one. Immunoglobulin M, or IgM, is a pentamer. It is a cluster of how many antibodies do you think? If a monomer is one, what is a pentamer? 5. Very good. It is a cluster of 5 antibodies and is effective in combining with foreign antigens. Also note that the antigen fits exactly into the antigen binding site. If it did not, it would not be able to bind. So this is almost like a lock and key, you guys. Antigen binding sites therefore have different structures depending on the antigen to which they are designed to bind. Does that make sense? If you look up, if you look up in that top right corner, you see the little black, looks like almost like a barbell there. That antigen and the binding site that it's going into, like it looks like we're playing Tetris here. It has to fit. It is molded to fit. It is designed to fit. So if it does not fit into there perfectly, it will not bind. Just like a lock and key. If it's not the correct key, it won't open that lock. If I get my screen to move now. Okay. Inflammatory response. Inflammatory reaction and immune response is independent processes that often occur simultaneously. Most common cause of inflammation are infection and injury. Acute inflammatory response involves vascular and cellular components. During inflammation, mast cells degranulate and release a variety of substances. After degranulation, mast cells release vasoactive amines. We're going to say amines. Histamine and serotonin increase vascular permeability. This causes vasodilation, and it can cause bronchoconstriction, nausea, and vomiting. Mast cells also synthesize leukotrienes and prostaglandins. Yeah, okay. Different plasma protein systems are complement system, coagulation systems, and the kinin system. All right, cellular components of inflammation. The polymorphonuclear neutrophils, PMNs, arrive at the sites to what? Does somebody say, woo? They arrive at the sites in the tissue where they are needed. The process involves two major stages, an intravascular phase and an extravascular phase. So during the intravascular phase, leukocytes move to the sides of blood vessels and attach to the endothelial cells. During the extravascular phase, leukocytes travel outside the blood vessels to the site of inflammation and kill organisms. So does that make sense? Intravascular, what are we talking about there? What is intravascular?
Inside
So inside the vessels. And the extravascular is working outside the vessels. All right. Cellular event sequence is margination, activation, adhesion, transmigration, and chemotaxis. All right. I think it's important to remember that event sequence. Cellular products of inflammation, cytokines affect the function of other cells. Monocytes release monokines. Lymphocytes release lymphokines. Interleukins attract white blood cells to the sites of injury and bacterial invasion. How can you remember that? Interleukins. How can you associate that with white blood cells?
the loop.
The loop. Interferon is a protein produced by cells when they are invaded by viruses. Lymphokines stimulate leukocytes. Macrophage activating factor stimulates macrophages to help engulf and destroy foreign substances. And migration inhibitory factor keeps white blood cells at the site of infection or injury until they can perform their designated tasks. How can we remember that?
Like the structures when we do mast cells.
So let's break down migration inhibitory. What does that mean? Migration, when things move around, right? They migrate. To inhibit that would mean what? What does inhibit mean?
Stop or slow.
Okay, so a migration inhibitory factor keeps the white blood cells at the site of infection or injury until they perform their designated task. It keeps them from moving anywhere else. It keeps them there. It inhibits migration. Makes sense?
Yes.
Yep.
All right. Injury resolution and repair. A normal wound healing involves 4 steps: repair of damaged tissue, removal of inflammatory debris, restoration of tissues to a normal state, and regeneration of cells. All right. Wounds heal by primary or secondary intention. A primary intention occurs in clean wounds with opposed margins. A secondary intention occurs in large, gaping, or infected wounds. This is more pronounced in prolonged inflammatory phase. Factors that lead to dysfunctional wound healing may be local or systemic. Local factors include infection, inadequate blood supply, foreign bodies. Systemic factors include inadequate nutritional intake leading to insufficient levels of collagen, and anything that interferes with epithelialization and wound contraction, hematologic abnormalities, diabetes, AIDS, and use of corticosteroids. A chronic inflammatory response is usually caused by an unsuccessful acute inflammatory response. It is associated with an infiltrate or pus containing monocytes and lymphocytes and usually involve tissue destruction and repair. This illustration shows the inflammatory response. So when you cut your finger, follow this chart. This is everything that happens to promote your healing. All right. It's important that you understand that. Variances in immunity and inflammation. Hypersensitivity is any response of the body to any substance to which a patient has increased sensitivity. An allergy is a hypersensitivity reaction to the presence of an agent. Autoimmunity is the production of antibodies or T cells that work against the tissue of one's own body. Isoimmunity is the formation of T cells or antibodies directed against the antigens on another person's cells. Types of hypersensitivity reactions. Type 1, immediate hypersensitivity reactions. This occurs in response to a stimulus and has a degree of, the difference in degrees of severity will vary. Type 2 is a cytotoxic hypersensitivity. Cells are destroyed by complement fixation or other antibodies. Type 3 is a tissue injury caused by immune complexes. This may be systemic or localized. A systemic form is serum sickness, which results from a large single exposure to an antigen. The localized form is an Arthus reaction. Type 4 is delayed or cell-mediated hypersensitivity, and the 2 subtypes of that are delayed hypersensitivity and cell-mediated cytotoxicity. This shows a type 1 allergic reaction and the process of that. That is going to be figure 818 in your book. The immune system targets different molecules depending on the type of hypersensitivity reaction. In allergic reactions, the target is an antigen or allergen. In autoimmune reactions, the target is a person's own tissues. Examples include Graves' disease, type 1 diabetes, rheumatoid arthritis, myasthenia gravis, and SLE. Immune deficiencies. Immunodeficiency is a body's immune system is inadequate and resistance to infectious disease is decreased. This can be congenital or acquired. Congenital immunodeficiencies is patients have inherited defects that involve the lymphoid stem cells. And acquired immunodeficiencies, what is that?
were gained.
Okay. What disease specifically? Acquired immunodeficiency. HIV, AIDS. Y'all, this is what AIDS stands for. Acquired immunodeficiency syndrome, AIDS. When we're talking about T cells, this is what we're talking about. We're talking about AIDS. Nutritional deficiencies may depress bone marrow function and diminish white blood cell development. It can be caused by trauma, iatrogenic immunodeficiency is caused by medication or treatment. Replacement therapy is available for immunodeficiencies. Factors that cause disease, they can be genetic, environmental, age-related, and sex-associated factors that can cause or contribute to the disease. Controllable versus uncontrollable risk factors. Uncontrollable factors such as genetics and race influence the development of disease. Many other factors such as smoking, drinking alcohol, inadequate nutrition, lack of physical activity, and stress can be controlled. The risk of a particular disease often depends on a person's age, and in some cases, sex is related to the risk of having a certain disease. The analysis of disease risk. This involves consideration of disease rates and disease risk factors. Causal factors are risk factors that directly cause a disease to, causal factors are risk factors that directly cause a disease to develop. Non-causal factors are risks that are associated with a disease but not a direct cause. All studies of a disease should consider the incidence, prevalence, and mortality of the disease. Risk factors can include age and sex differences, and they often interact. Common familial disease and associated risk factors. A true genetic risk is one that is passed through generations by inheritance of a gene. Diseases with a familial tendency seems to cluster in a family group despite lack of evidence for heritable gene-associated abnormalities. Immunologic diseases are caused by hyperactivity or hypoactivity of the immune system. A person who has an allergic tendency is said to be atopic. Don't know why they wanted you to know that, but they did. All right, figure 819 shows the pathogenesis of an allergy. First, you have an exposure to an allergen. This induces the formation of specific immunoglobulin E, so IgE, antibodies in susceptible patients. That then binds to mast cells and basophils. Subsequent exposure to the same allergen leads to antigen-antibody interaction through activation of memory cells, liberating histamine and other mediators from mast cells and basophils. These mediators induce allergic manifestations. So what all of that is saying is when your body first recognizes this allergen, and it can be anything, it's not necessarily something that is going to hurt you or try to attack you, your body, for whatever reason, sees this as a threat. For whatever reason, Maddie's body thinks tree nuts are out to kill her. So, the body sees it, and they're...
They are out to kill me. I tried. They tried to kill me.
Yes. So, her body will kill itself to keep the tree nuts from killing her. So what happens is, and I'm sure you've all heard, oh, you're not going to have an allergic reaction until the second time you're exposed to it, correct?
Yeah.
You've heard that?
Yes, I've heard that.
Okay. So what happens is your body sees this, and your body says, okay, this is not safe for me. I don't like this. So it releases all of these antibodies to try to protect you from it. They wrap around this thing, whatever it is that you're allergic to. They wrap around it, they bind to it, and then they activate these memory cells. What do you think memory cells do?
Remember.
They remember. They remember. So the next time that this, whatever it is, enters your body and your body sees it, those memory cells do what? They remember it. They look at it. They say, I remember you. And then they release all of these histamines and mediators from the micelles and basophils to attack it and kill it. Okay? So that's how an allergic reaction occurs. You're exposed to it, your body recognizes it, thinks that it's shady, sends these things to bind to it, send other cells to memorize it, so that the next time it sees it, whether it's tomorrow or in 10 years, it's going to see it again, it's going to remember it, and it's going to attack it. Does that make sense? Yes. Okay. Cancer. This describes the pathology associated with malignant growths in various anatomic areas. The prognosis often depends on the extent of its spread or metastasis and the effectiveness of treatments. Breast cancer is the most common type of cancer occurring among women. Colorectal cancer is the third most common type of cancer in men and women. Diabetes, one of the most significant endocrine diseases, associated with partial insulin secretion or total lack of insulin secretion by the pancreas. Ketoacidosis prone, type 1 or insulin dependent diabetes, and you have non-ketoacidosis prone, which is type 2 or non-insulin dependent diabetes. What age group is most affected by type 1 diabetes?
Mid-teens through life.
Yes. So this is most of the time type 1 insulin dependent. Most of the time this is discovered in younger children. So this is a lifelong thing. You're going to have a lot of patients. And if you have a patient and you ask them, hey, are you insulin dependent or are you non-insulin dependent, type 1, type 2, however you word it, if they tell you type 1 and you ask them when they were diagnosed, they're going to give you a pretty young age. They've been dealing with this their whole life. You can ask Blake, and Blake can educate you on this stuff. It's not easy, and it's sure not fun.
That's right. It's awful.
Yes, it is, and again, like it says, one of the most significant endocrine diseases. Hemolytic disorders. Hemolytic anemia is characterized by increased destruction of red blood cells. This disorder has a number of causes, such as an Rh factor blood transfusion reaction, a disorder of the immune system, and exposure to bacterial toxins or chemicals such as benzene. Hemophilia is an inherited disorder characterized by excessive bleeding. That's what we call free bleeders. One of the blood clotting proteins necessary for blood coagulation is absent. Hemochromatosis is an inherited disease in which the body absorbs more iron than it needs. Cardiovascular disorders, you have cardiomyopathy, which is diseases of the myocardium, mitral valve prolapse, coronary heart disease. This is caused by impaired circulation to the heart. hypertension or high blood pressure, and stroke. Figure 822 shows a comparison of normal cardiac function with malfunction characteristic of hypertrophic cardiomyopathy. In figure A, you have a normal heart illustrating unobstructed flow of blood from the left ventricle into the aorta during ventricular systole. Hypertrophic cardiomyopathy in figure B illustrates obstruction to outflow of blood from the left ventricle by hypertrophied septum, which impinges on the anterior leaflet of the mitral valve. Renal disorders. Gout is an abnormal accumulation of uric acid and kidney stones. That looks like a dinosaur nugget. Okay, GI disorders. You have malabsorption disorders. What is malabsorption?
It doesn't absorb properly.
Does not absorb properly. Lactose intolerance, ulcerative colitis, Crohn's disease, peptic ulcer disease, gallstones, and obesity. Obesity is a body mass index greater than 30 kilograms per meter squared. Morbid obesity is a BMI of 40 or greater. Overweight is a BMI of 25 to 29.9, and it is caused by genetic and behavioral or environmental factors. Neuromuscular disorders. You have Huntington's disease, muscular dystrophy, multiple sclerosis, Alzheimer's disease. Psychiatric disorders. Some common psychiatric disorders have a familial or genetic component. Schizophrenia and bipolar disorders fall into that category. Stress and disease. Stress includes a wide range of strong external stimuli, physiologic and psychological, that can cause a physiologic response. Physiologic stress is a change that makes it necessary for the cells of the body to adapt. Concepts related to physiologic stress include the stressor itself, its effects on the body, and the body's response to the stress. A general adaptation syndrome characterizes a three-stage reaction to stressors, physical and emotional. Stage 1 is alarm. This is when the body reacts to stress first by releasing catecholamines. What are the catecholamines? Epinephrine, norepinephrine, dopamine, or you might hear them say adrenaline, noradrenaline, and dopamine. Stage 2 is resistance or adaptation. The body attempts to adapt to stressors primarily by stimulating the adrenal gland to secrete glucocorticoids and mineralocorticoids. The anterior pituitary releases the adrenocorticotropic hormone, or ACTH, and endorphins are released. Stage 3 is exhaustion, and the adrenal glands become depleted, decreasing the blood glucose level, resulting in decreased stress tolerance, progressive mental and physical exhaustion, illness, and eventually collapse. So this shows the physiologic response to stress, everything we just talked about, how that happens in order. So the pink arrows are going to go over the sympathoadrenal pathway, and the orange ones are the pituitary adrenal axis. So figure 826 shows how stress triggers secretion of the adrenocorticotropic hormone, which results in, what do you think it secretes? Anybody? Cortisol. Cortisol. Are y'all still with me? You still here?
Oh, here.
Me and Caitlin just got back.
I'm here.
Okay. So the effects of chronic stress. You have hypothalamic pituitary adrenal axis. This controls the reactions to stress. Continued stress leads to loss of normal control mechanisms of the hypothalamic pituitary adrenal axis. The adrenals continue to produce cortisol, which exhausts the stress mechanism, leads to fatigue and depression, and interferes with serotonin activity. A consistently high cortisol level suppresses the immune system, and coping mechanisms play a role in the physiologic response to stress. Effective coping mechanisms can help a patient improve his or her immune system response. All right.